Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're getting into something really fundamental, open inguinal hernia repair. If you're a new general surgeon, well, this is probably the bread and butter procedure you'll be doing a lot of. It's super common, sure, but mastering it, that takes real precision. Getting it right consistently early on kind of sets the tone for your whole career. So our mission today is pretty straightforward. We want to break down the step-by-step for this surgery, really focusing on what you, as a new surgeon, need to know. We'll cover everything from the initial workup right through to recovery.
Exactly. And we're drawing this from a really solid guide that simplifies a lot of complex info. The sources really distill years of experience into something practical. It's all about safety, precision, and ultimately good patient outcomes. Understanding why you do each step is just as important as knowing the step itself. It's how you minimize complications, you know?
Okay, perfect. Let's unpack this then. Let's start before you even make a cut because, well, surgery really starts way before the OR table, doesn't it? First things first, patient evaluation. Obviously, you need to confirm the diagnosis history, physical exam. Sometimes an ultrasound helps if things aren't crystal clear. But what about those things that maybe junior surgeons might gloss over? I'm thinking risk factors.
Oh, absolutely critical. You need to actively look for things like obesity, COPD, BPH, benign prostatic hyperplasia, and smoking. These aren't just footnotes. They can seriously impact the surgery and recovery. Think wound healing, breathing issues post-op.
Right. And obviously ruling out the big contraindications, active infection, maybe uncorrected coagulopathy. You just wouldn't proceed then.
Definitely not. And then there's consent and anesthesia. This isn't just paperwork. You have to explain the real risks.
Like what specifically?
Well, recurrence is one. It's maybe 1-3%, but patients need to know. Then there's chronic pain, which, can affect around 5-10% of people. When I talk about chronic pain, I usually frame it like, look, a small percentage experience some ongoing discomfort. It's usually manageable, but it's important you're aware. Helps set realistic expectations. And of course, the general stuff, infection, hematoma, maybe even injuring something nearby, like the bowel or bladder, though rare. Thorough consent is about safety and satisfaction.
That makes sense. And anesthesia options?
Usually local, spinal, or general. Depends on the patient-surgeon preference, the whole picture.
Okay, so consent's done, patient's ready. Positioning and prep seems basic, but crucial.
Totally. Supine position, arms tucked gently. Then the prep. Shave if needed, antiseptic prep, and drape really wide umbilicus down to mid-thigh. You need that sterile field.
Right, gives you room to work without contaminating anything. Okay, prep done. Now let's get into the core of it, the actual surgical steps. This is where it gets really interesting for someone learning. Step 1, the incision. Sounds simple, but where exactly are you aiming? What's the landmark?
Precision starts here, think, about 2 centimeters above the inguinal ligament running parallel to it. A nice, clean incision, maybe 5 to 7 centimeters long, kind of following the natural skin crease if you can.
Okay.
You go through skin, then subcutaneous fat, scarpa's fascia. But the layer you're really aiming for is that glistening white layer underneath the external oblique aponeurosis. That's your key landmark.
The external oblique aponeurosis.
Okay.
Got it.
So that brings us to step 2, opening that layer and finding the inguinal canal. What's the critical move here and what's the big uh-oh to avoid?
Okay, so you incise the external oblique along its fibers, and here's the first major nerve alert.
No.
Watch out for the ilioinguinal nerve. It's often right there, superficial. Nicking it is a common cause of, well, post-op pain.
Once you're through, you retract the flaps gently, and that nicely exposes the inguinal canal underneath. Now the real nerve hunt begins.
Okay, nerve hunt. Which ones are we looking for?
3 main players you have to identify. The ilioinguinal, which you might have already seen, often runs right on the spermatic cord. Then the iliohypogastric, usually a bit higher up, more superior. And the genitofemoral, which is deeper, sometimes harder to spot, near the vessels.
And identifying these isn't just academic, is it? It directly relates to preventing that chronic pain issue we mentioned.
Exactly. It's maybe the most common significant complication, that chronic groin pain. Taking that extra minute to find and protect these nerves, it's absolutely non-negotiable. Saves the patient a lot of potential misery.
I remember an attending saying, if you don't see nerves, you're not looking properly. Stuck with me.
Good advice. So, nerves identified, hopefully protected. Now, step 3, mobilizing the spermatic cord. Why is this such a key step?
You need to get the cord completely free, circumferentially, so you can properly see the floor of the canal and deal with the hernia sac itself.
How do you do that gently?
Usually with blunt dissection, often using a moist peanut sponge, you're carefully teasing the cord structures away from the surrounding tissue, the floor of the canal.
And you mentioned a risk here, the sliding hernia.
Ah, yes. You have to be aware, especially with large indirect hernias, that part of the wall of the hernia sac might actually be the bladder or the colon sort of slid down. If you're not careful dissecting, you could inadvertently injure those organs. So, yeah, extra caution needed there.
Good point. Okay, cords mobilized. Step 4. Identify the hernia sac. How do you tell what kind of hernia you're dealing with? Indirect versus direct.
It's usually about location relative to the cord. An indirect hernia sac comes through the deep inguinal ring, so it'll typically be within the cord structures, often anteromedial. It's basically a remnant of fetal development that processes vaginalis.
Okay. And a direct.
A direct hernia is different. It's an acquired weakness that bowls through the floor of the inguinal canal through Hasselbalch's triangle, so it'll be medial to the cord structures, not really part of them.
Is there a quick way to tell if you're unsure?
Yeah, a neat little trick sometimes is to reduce the bulge, have anesthesia lighten the patient slightly if possible, or just gently press, then ask the patient to cough or apply some pressure. A direct hernia often pops straight back out, medial to your finger if it's over the deep ring. An indirect usually stays reduced a bit longer or comes down the canal.
That's useful. And why is knowing the type so important?
Because it dictates the next step, step 5, dissecting and reducing the hernia sac. The approach is different.
Right. So walk us through an indirect hernia first.
Okay, for an indirect hernia, especially if it's large, you'll carefully open the sac. Check what's inside, usually omentum or maybe even bowel. You gently reduce those contents back into the abdomen. Then comes the crucial part, high ligation. You dissect the sac right up to its origin at the deep inguinal ring and tie it off high with an absorbable suture like a Vicryl 2.0.
What about small indirect sacs?
Sometimes, if they're really small and thin-walled, you might just be able to invert them back through the deep ring without actually opening them or ligating. But high ligation is the classic definitive step.
And that high ligation is key, right, to prevent recurrence.
Absolutely critical for indirects. You're essentially closing off that persistent connection from the abdomen. If you ligate too low, you leave a funnel, basically inviting recurrence.
Makes sense. Now, what about direct hernias? You said the approach is different.
Totally different. With the direct hernia, there isn't usually a distinct sac to open or ligate like an indirect. It's more just a weak, bulging area of the transversalis fascia, the floor of the canal. So for a direct hernia, you basically just reduce the bulge, push the weakened tissue back, and then the main job is to reinforce that weak floor, usually with mesh. No high ligation needed because there's no congenital sac defect there.
Got it. So identify the type, manage the sac or lack thereof appropriately, which leads us nicely into step 6, mesh placement. You mentioned the Lichtenstein technique being the gold standard. Why is that?
Well, before Lichtenstein, most repairs involve sewing native tissues together, often under tension. Imagine pulling weak fabric tight. It tends to tear or stretch out again, right? High recurrence rates.
Exactly. Lichtenstein's big idea was the tension-free repair using a synthetic mesh, usually polypropylene, maybe around 7.5 by 15 centimeters. It acts like a scaffold, reinforcing the area without pulling tissues together tightly.
Okay, so how do you actually place the mesh using this technique?
You tailor the mesh to fit the inguinal floor. Key steps are: suture the medial end securely to the pubic tubercle, that's a critical anchor point, using a non-absorbable suture like Proline 2.0. Then you make a slit in the lateral end of the mesh to create two tails, which wrap around the spermatic cord.
Okay, accommodating the cord.
Yep. Then you suture the lower edge of the mesh to the inguinal ligament and the upper edge to the conjoint tendon or internal oblique muscle superiorly.
And the most important principle here, no tension. The mesh has to lie completely flat, like a patch, with no folds or buckling. It should just comfortably reinforce the floor. That tension-free aspect is what dramatically lowered recurrence rates.
Brilliant. Okay, mesh is in place, looking good. Final step before skin closure. Step 7, closing the external oblique.
Right, you bring the edges of that external oblique aponeurosis back together over the mesh and cord, usually with an absorbable suture like Vicryl 3.0. Just make sure you don't accidentally catch a nerve in those stitches.
Good point. Then subcutaneous tissue.
Yep, close the subcutaneous fat layer with a few interrupted absorbable sutures to reduce dead space. And finally, skin closure could be staples, could be a running subcuticular suture, kind of surgeon's preference.
Okay, so that's the operation itself, step by step. Now, the patient's heading to recovery. Let's talk post-op care and, importantly, avoiding complications.
Absolutely. Post-op care starts with pain control. Usually a combination of NSAIDs, maybe some acetaminophen, and sometimes local anesthetic infiltrated during the procedure helps a lot initially.
And activity. What do you tell patients?
The standard advice is no heavy lifting, think more than 10 kilograms, or about 20 pounds for usually 4 to 6 weeks. Give that mesh time to incorporate. But light activity, walking around, that's encouraged pretty much right away, maybe after day 1 or 2.
And follow up.
Crucial. Usually see them back in a week or 2 to check the wound, look for any early signs of trouble like hematoma, infection, and just generally see how they're doing.
And connecting this back, good post-op care isn't just about comfort, is it? It impacts the outcome.
Definitely. Good pain control means they can mobilize earlier, reducing risks like DVTs. Following activity restrictions helps prevent early recurrence or mesh disruption.
Are there any subtle signs in this first couple of days that a new surgeon should be really alert for? Things that might signal a brewing problem?
That's a great point. Maybe pain that seems way out of proportion to what you'd expect, or pain that's not responding to the usual analgesics, maybe persistent nausea or vomiting, or even just a low-grade fever that doesn't quite fit, or increasing redness or warmth around the incision. Catching those early is key.
Right. Now let's talk explicitly about complications and how the steps we discussed help prevent them. Recurrence, for instance.
Yeah, recurrence prevention comes down to meticulous technique.
Yeah.
Getting that good mesh overlap, especially medially over the pubic tubercle, secure fixation without tension, and for indirect hernias, that all-important high ligation of the sac.
And chronic pain.
Nerve identification and preservation. Avoiding trapping the ilioinguinal, iliohypogastric, or genitofemoral nerves, either during dissection or in the mesh fixation or closure, that's paramount.
Infection.
Strict sterile technique throughout the procedure, obviously, and minimizing hematoma blood collection, because that's a great place for bacteria to grow. Gentle handling of tissues helps there.
What about seroma, that fluid collection?
Again, gentle dissection helps minimize tissue trauma and fluid leakage. Some surgeons might use compression dressings post-op, though the evidence on that is a bit mixed. Mostly it resolves on its own, but minimizing dead space helps.
And the really feared one, the rare, testicular atrophy.
That comes down to being careful with the spermatic cord. Avoid excessive stripping of the cremasteric muscle fibers or skeletonizing the cord too much, which could compromise blood supply. Gentle handling is key.
So it really all ties back to careful, precise technique at every single step we discussed.
Absolutely. Okay, let's try and boil this down. For a new surgeon facing this, what are the absolute must-remember, non-negotiable takeaways from our deep dive? We came up with 4 key things. First, always identify those 3 nerves, ilioinguinal, iliohypogastric, genitofemoral. Make it a habit.
Critical.
Second, high ligation for indirect hernias is essential. Don't skimp on dissecting the sac high enough.
Yeah.
Third, mesh overlap. Make sure that mesh extends 1 to 2 centimeters medial to the pubic tubercle. That's a common spot for recurrence if you don't get enough coverage there.
Crucial detail.
And fourth, avoid tension. The mesh must lie flat. No wrinkles, no tightness. Tension-free is the name of the game.
Those 4 points really capture the essence of a solid Lichtenstein repair.
So what does this all mean? Look, open inguinal hernia repair is fundamental. You're going to do a lot of these. Getting it right matters hugely for your patients. For a new surgeon, though, facing it the first few times, it can still feel, a bit daunting, right? All these steps, the nerves. What's one piece of advice for managing that initial anxiety?
That's natural. I'd say confidence comes from preparation. Review the anatomy again right before. Mentally walk through the steps. Don't ever be afraid to ask your senior resident or attending for help or clarification during the case. True mastery comes from doing it, reflecting on it, and learning from each one. Humility is key. But focusing on that anatomy, the mesh placement, protecting those nerves, nail those things, and you'll minimize complications and get consistently good outcomes for your patients. It's about building competence, and the confidence follows.
Well said. And it's worth considering, isn't it, how mastering this seemingly routine procedure, this intricate dance of anatomy and technique, doesn't just fix a hole. It really impacts someone's daily life, their comfort, their ability to work and live normally. It makes you think, what other foundational skills, when we really apply ourselves meticulously, have the kind of ripple effect on well-being, something to mull over?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.